Hello, my name is Brigitte Fitzsimmons, and I am a nursing student at Glacier Hills Rehabilitation Center. I'm going to present a patient to you. Patient is a 66-year-old married, obese Caucasian male. He works at their family business at a desk job. His usual source of medical care is St. Joseph's Hospital. He was admitted to St. Joseph's on July 19th for a thoracentesis for pericardial and pleural effusion. He was admitted to Glacier Hills Rehabilitation Center on August 2nd for recovery. His chief complaint when admitted to St. Joseph's is that he was short of breath, a complaint he has had for 3 years that gradually worsened. His shortness of breath worsened with movement. Walking more than 10 steps and climbing the stairs aggravated his shortness of breath. There were no alleviating factors. Patient's shortness of breath interfered with his ADLs. He had trouble completing tasks such as laundry, walking up the stairs, walking to the car, and walking from the living room to the kitchen for dinner. Patient denies chest pain. Patient has edema in his lower extremities. Patient says his general practitioner and cardiologist noticed some fluid around his heart 3 years ago, but not a significant amount. Over the last 3 years, patient states doctors knew he was losing blood, but did not know how or where. When patient received thoracentesis for pericardial and pleural effusion, a total of 1.5 liters of fluid were drained from his pericardium and 8 liters of blood were drained from his lungs. Patient states the thoracentesis has helped his breathing, but his recovery is longer than expected. Vital signs are stable, pulse is 72, and respiratory rate is 20. Past medical health history, patient is diagnosed with enlarged heart, atrial fibrillation, osteoarthritis, carpal tunnel, sleep apnea, hypertension, hyperlipidemia, and type 2 diabetes. Patient is up to date on all immunizations and received his flu and pneumonia vaccine last winter. Drug allergies include Dilaudid with a reaction of diarrhea and confusion, and morphine, which patient states caused heart problems. Past surgeries and hospitalizations. Patient received hip replacement in March of 2010. Patient was hospitalized after thoracentesis for pericardial and pleural effusion. Patient is now in rehab. Current medications. Doctor has currently stopped patient's normal schedule of medications and is reestablishing a new medication schedule. Patient is currently only taking aspirin 1 time a day orally to avoid CVA and insulin injections to stabilize his glucose levels. Prior to this, patient took Lipitor for high cholesterol, ferrous sulfate for an iron supplement, Terrazim for hypertension, and numerous medications to relieve constipation. Functional assessment. Patient does not use illicit drugs or alcohol. He does not smoke, but was heavily exposed to secondhand smoke by his wife, mother, and father. He does not exercise regularly because of his arthritis and shortness of breath. However, he participates in occupational and physical therapy at the rehabilitation facility once a day. Patient claims OT and PT are difficult and complains of shortness of breath. Patient sleeps 8 hours each night with a CPAP machine. His sleep quality was lower at the rehabilitation center because he did not have his CPAP machine. Patient does not drink coffee or tea. Patient drinks 1 soda each day. At home, patient uses a cane to help him walk from the car to his front door. Increased use of cane in the past few months due to shortness of breath. Psychosocial data. Patient lives with his wife of 45 years in their 3-story condo in Ann Arbor, Michigan. Patient states he is very close with his daughter, who lives 1 mile away. Patient values spending time with his daughter's 2 dogs, and he brings them to work daily. Patient rates stress as being relatively low. However, patient's wife and daughter have experienced health issues in the past that have caused the patient stress. In addition, patient's deceased mother caused an ongoing lawsuit since 2009 that was just settled in 2010. Patient reports most of his stress was a result of the lawsuit. Patient experiences no environmental hazards. His home and work are in a clean and safe environment. Patient identified as Catholic but is not very actively religious. Patient received his BSBA at Butler University. Patient addresses his healthcare needs regularly and sees his general practitioner annually. Family history. Dad has atherosclerosis and died of a myocardial infarction at age 65. Mom had congestive heart failure and Alzheimer's and died at age 85. Sister had nephritis as an infant. Daughter has many undiagnosed medical conditions and possibly lupus. Review of systems. Patient describes health as 8 out of 10. He states he is in good health other than his shortness of breath and obesity. His energy level has decreased with his shortness of breath the past 3 years. Patient states he has experienced an increased cold intolerance. Cardiac. Patient is recovering from a thoracentesis for pericardial effusion. Therefore, it is important to perform a cardiac assessment. Patient denies chest pain or numbness. Patient is diagnosed with hypertension and controls it with myocarditis and terazim. Patient has mild heart murmur. Patient states he received his last EKG in July of 2015 and prior to that, February and March of 2015. Patient states he received a stress test in January 2015 and an echocardiogram in July of 2015. Patient denies a history of myocardial infarction, congestive heart failure, arterial sclerosis, coronary artery disease, angina, and valvular disease. Patient states the possibility of having rheumatic fever as a child. Patient experiences dyspnea when lying down and alleviates this with 2 pillows under his knees and 1 pillow under his head. Patient has high cholesterol and was previously prescribed Lipitor. High triglyceride levels. Patient denies heart palpitations. Upon examination, no heaves or lifts are observed over the aortic, pulmonic, Erb's point, and tricuspid and mitral areas. Patient's contour was normal. 3 scars noted from thoracentesis procedure. When palpated, no lifts or thrills were felt. Upon auscultation, the aortic, pulmonic, Erb's point, tricuspid, and mitral areas were auscultated. A mild heart murmur was heard. Apical pulse was auscultated. No abnormalities were found other than the heart murmur. Respiratory. Patient's chief complaint is shortness of breath, and he is currently recovering from a thoracentesis for pleural effusion. Therefore, it is important to perform a respiratory assessment. Patient complains of shortness of breath affecting his ADLs. Denies wheezing or pain when breathing. Patient states he coughs frequently since the thoracentesis procedure. Patient does not exercise frequently and becomes short of breath when walking short distances. Patient denies history of asthma, bronchitis, or pneumonia. Patient denies family history of respiratory disease. Upon examination, patient's color was normal. His AP transverse diameter was normal 2-to-1 ratio. No injuries or deformities were observed. Chest was symmetrical. Patient's breathing pattern did not show any distress, although his respiratory rate was slightly elevated at 20 breaths per minute. Upon palpation, patient's trachea was midline. Thoracic expansion and tactile fremitus was normal. No masses or abnormalities were palpated on the ribs of thorax. Upon auscultation, lung fields were clear anteriorly, laterally, and posteriorly. No wheezes, crackles, or bronchi were auscultated. Normal results for bronchophony, egophony, and whisper pectoriloquy, and no signs of consolidation. Pertinent system number 1, musculoskeletal. Patient experiences pain and limited ability to perform ADLs and exercise because of osteoarthritis. Patient also had a hip replacement in 2010. According to the Journal of Epidemiology and Community Health, it is important to assess musculoskeletal because of the correlation between increasing age and osteoarthritis and the benefit of exercise to reduce osteoarthritis pain. It is evident that my patient's arthritis stops him from exercising. This would be an important opportunity to not only assess his arthritis and his pain, but to educate him on the importance of moving around to decrease his level of pain and improve his ability to perform ADLs. Pertinent system number 2, peripheral vascular. Patient reports limited mobility due to shortness of breath because of pericardial and pleural effusion and his pain experienced because of osteoarthritis. His limited mobility and obesity puts him at risk for a pressure ulcer. According to medical care, it is important to assess peripheral vascular because an obese patient with decreased mobilization has an 18.9% higher risk of developing a pressure ulcer. Therefore, a peripheral vascular assessment would be important to assess any signs of a pressure ulcer.